recently presented a similar webinar series for the Pennsylvania Association of Community Health Centers. So I will now hand it to Christina to get us started today.
Thanks, Christy. All right. So, good afternoon, everyone. We were just talking before you came on about the weather here. I'm glad to hear you guys are not affected by the wildfires in Canada. We're getting hit. We have really, really smoky skies. It's just kind of gross, but I'm glad you guys are not. We must be on the right wind stream this time. So, let's get started with third trimester prenatal care. If you want to bump to that next slide, this is the same disclaimer you've seen in prior presentations. If you're watching a recording of this, please check the date of the recording as this can affect the validity of what's being presented. Remember that evidence-based practice changes how we interact, how we manage, and how we treat patients on a regular basis. And I recognize that these are the recommendations based on evidence-based medicine, right? But it's our job to educate the patient on the recommendations. But as clinicians, we live in these communities with these patients. We're familiar with some of the hurdles that they're facing, and we know that can make it difficult to follow these recommendations and make them not as realistic for every patient. So I just ask that you work with your patients and understand, what options are out there for them and what we do recommend, but understanding that it might not be realistic for everybody. All right, let's move on to the next one here. As we saw in the prior presentations, the third trimester is from 28 weeks until 40 weeks and 6 days, or basically 1 week over their estimated due date. Moving on to that next slide, our patients here in the third trimester, they'll be in those every 2-week visit categories for a bit, and then they're going to transition to those weekly visits for the last month or so of the pregnancy. But remember, ACOG is tailored or supporting that tailored prenatal care, which means you as the clinician and the patient can kind of set the frequency of the visits depending on the patient's needs and, what the patient's resources are and what your clinical judgment is. So feel free, this is the recommended old school, what we've been doing forever, but it does not have to be exact to this. All right, moving on to the next one here. Goals in the third trimester, we're going to want to assess fetal growth. We're going to want to get ready for delivery in many ways. We're going to identify GBS, remember, is group B strep positive mothers. We're going to screen for sexually transmitted infections when indicated. And then those last two bullets were the same as our goals in the second and third trimester. Moving on to the next slide, I'm going to touch on STI screening in the third trimester first. There's no set time as to when you should screen. Most commonly, it's around 28 to 36 weeks. A lot of the timing really depends on if the patient tested positive earlier in the pregnancy, or if you know that they're at high risk for being exposed to an STI during the pregnancy or even since her last visit. In some cases, the earlier in the third trimester you can obtain the information, the more time that you will have then to intervene, before delivery. Appropriate intervention peripartum can really significantly reduce concerns. And, one of the biggest ones is perinatal HIV transmission. The goal is to get mom's viral load at less than 1,000 copies using treatment. And the hope is to decrease vertical transmission significantly, making them candidates for a vaginal delivery. And as you can imagine, if you only really detected that at 36 weeks, so a week before or a month before their due date, we don't have as much room to work with. So just really take the patient into consideration in terms of when you're testing and their risk factors. So for like HIV specifically, a viral load less than 50 copies, your rate of transmission is less than 1%. If you get that viral load, less than 1,000, so between like 50 and 1,000, you move to 1 to 2% vertical transmission risk. But then if you can get that, if that viral load stays above 1,000, really they're not even candidates for vaginal delivery anymore. Now they're an automatic C-section at like 38 weeks. So it really changes our delivery plan depending on how well we can control them. So knowing information sooner can be helpful. Just keep that in mind. All right, moving on to the next one. Um, just in case you were trying to remember what are those items that you should be thinking about that would be increased risk for STIs, I did just go ahead and kind of list them out here for you. Certainly you can take a peek at those later on, but they're pretty intuitive, right? Things we already know. All right, next slide. Change topics just a little bit. Let's talk about those common patient concerns in the third trimester. I'm going to talk about each of these a little individually. So Braxton Hicks contractions, patient really describes these as a feeling of like tightness of the uterus. It's not always painful. They do tend to vary in intensity and length. They're more likely to happen like kind of later in the day, after activity, or even after or associated with intercourse. They really should improve with rest and fluids. And generally, if they're getting more than about 6 in an hour, especially with rest and fluids, are not improving, then you would want to recommend further evaluation. Musculoskeletal pain, we talked about this a little bit in prior webinars. Back and pelvic pain are by far the most common. Physical therapy is huge. Low back exercise is also huge. And these are definitely warranted for some patients. Shortness of breath, this is still a little bit hormonal, but now it's becoming more anatomical in this third trimester, right? Those lungs cannot expand down as far as they used to. We talk about good posture, trying to get mom to sit upright to allow room for the lungs to be as large as they can. But we definitely see that anatomically we're starting to compress in this third trimester. The GI system takes a hit in pregnancy as hormones tend to kind of slow digestion for most women. And the uterus also starts to press on the intestines. And so you're going to see things in terms of heartburn and constipation and, all that comes with that. Not uncommon. The vasculature system responds to this increase in blood flow, but also now the compression of the large uterus. You're going to see the increase in the lower varicosities of the legs, sometimes even varicose veins of the labia, hemorrhoids. All of these things are not uncommon for your patients to bring up. Speaking of compression from that large uterus, we continue to have frequent urination. The bladder feels this space squish, and although first trimester tended to be more hormonal, now we do see this anatomical part as well with frequent urination. And you can also see pretty significant nausea and vomiting return in the third trimester. So that second trimester is when people really start, they feel good. And then that third trimester can hit them again. So the nausea and vomiting can pick back up. That is not necessarily abnormal, but do make sure that they are well nourished, well hydrated, and that you rule out anything else that could possibly be affecting. And obviously they can still get a GI bug, or the norovirus that's going around. Always keep that in mind too. All right. On to the next one. Just as we discussed in the second trimester, these are those 4 big important questions you'll want to ask. Any vaginal bleeding, any leaking of fluids, are you feeling baby move, and any abdominal or pelvic pain that does not go away with rest and fluids and that is consistent. These need to be asked at every single visit when you interact with the patient. We talked about these more specifically on that second trimester one, so I'll refer you back to that lecture. Next slide. Here we are at the beginning of the third trimester, 28 to 30 weeks. These are our every 2-week visits. This list should look really familiar as it's the same as the majority of the second trimester visits. Around this time, you want to ensure that they've completed their screening for gestational diabetes and anemia. And if they did not pass their initial glucose screening, make sure that they've completed their 3-hour test by around about 30 weeks. We like to have it done. Unless, of course, their 1-hour gestational glucose testing was over 200, then they don't even need to do the 3-hour test. They're automatically considered gestational diabetic. And I think we talked about that at the last one as well. But just make sure that it is done and we have those numbers. Sometimes patients have to be reminded, or we need to help them find a way to get to the lab or whatever. All right. Moving on to the next one here. 30 to 32 week visit, pretty standard. Not that you aren't already doing this, but this is where you're going to really want to start watching for blood pressure changes around this time. Are you starting to notice an elevation in their blood pressure? Now they're also having, lower extremity edema. Make sure it's bilateral, not unilateral. They're starting to throw some protein in their urine. All not unusual. It can happen and not be a diagnosis of anything other than pregnancy, but you want to be alert to it and know that it can be happening. Are they having more consistent headaches? Are they having visual changes? And we'll talk about that a little bit later in the pregnancy, why those matter. Or we'll talk about those a little later in the lecture and why those matter. All right. You can see for this 32 to 34 week list, I added fetal position. Although there is still time for baby to move into position, you need to start being aware of babies that are maybe non-cephalic. So they're breech, they're transverse, they're oblique, especially if you have a baby who is not cephalic. And we already know they're on the higher end of the estimated fetal weight, and or we know there's not a lot of amniotic fluid, there's less chance they're going to turn, right? They don't have, either maybe they're bigger, or B, they don't have as big of a swimming pool to turn in. So those babies are going to be more high risk to not eventually get themselves into the right place. Okay. All right, so on to the next one here. Now is a good time to kind of bring up specifics on the assessment of fetal growth. If the patient doesn't have any risk factors for fetal growth concerns, then measuring their fundal height, seeing it increasing appropriately and concordantly with their gestational age means that there's really no further testing that's needed. But what if that fundal height is not concordant? That's when you need to start thinking. It's one of the times you need to start thinking. You need to typically order an ultrasound for fetal growth. Specifically, on that, you're interested in the estimated fetal weight. They'll usually give you that, abdominal circumference, and they'll also usually give you the AFI or the amniotic fluid index or amniotic fluid volume. If those are normal, then you go back to the routine screening and measuring of fundal heights, right? You don't have to do anything. If they're abnormal, then this is where you may need to consider having them see a specialist or maternal fetal medicine. Sometimes they need to look at the blood flow through like fetal Dopplers, umbilical artery Dopplers. Sometimes they'll do NSTs, sometimes they'll do biophysicals, and you need to talk about appropriate time for delivery. We'll talk about small babies and big babies here in a little bit. But let's go back to kind of the top of this thought process. What if you have someone who is high risk for a fetal growth issue, or they're not really an appropriate candidate to kind of serially be measuring their fundal height measurements? And this type of patient would be the patient who has a history of a baby with small for gestational age or large for gestational age, or they have known uterine fibroids, or they have known multiple gestation. We wouldn't suspect their fundal height to be really very helpful, right? What if the patient is morbidly obese? Measuring this patient's fundal height is not overly accurate, so you are going to need to consider a fetal growth ultrasound at some point. Okay. Typically, they're started around 20 or around 32 weeks, sometimes 28 weeks, and we typically don't do them any sooner than every 3 to 4 weeks. You don't really see a statistically significant change in just like a 2 week interval of fetal growth. If the growth is abnormal, sometimes they will continue to serially check the fetal Dopplers, which is the blood flow, umbilical artery Dopplers, I should say. But that's not something you're going to be doing in your office. But if you're getting a growth scan, every 3 to 4 weeks is appropriate. You don't need to do it too much sooner than that. Unless you have a suspicion that something is acutely wrong, like they're ruptured membranes and they have no fluid potentially, something like that. If at any time that growth is abnormal, abdominal circumference is off, AFI is low, this is when you would want to refer to them to further testing. All right, I'm going to move on to that next one here. In regard to growth restriction or small for gestational age, ultrasound is indicated only for pregnancies at high risk for fetal restriction. So a meta-analysis of randomized trials found that routine ultrasound exam in the latter part of pregnancy did not reduce perinatal mortality, preterm birth, induction of labor in low risk pregnancies. So if somebody's low risk, if they're not high risk, it just doesn't seem overly helpful to be using those ultrasounds for fetal growth. Some patients request them. We don't necessarily need them based on the studies. Um, so the routine use of the ultrasound for growth wasn't necessarily harmful. We weren't causing any harm, but it does increase maternal anxiety. And so that is something you want to keep in mind. You don't want to send your patient down a rabbit hole and see something incidental or something that wasn't overly necessary to know and cause more problems. Okay. Compared with serial fundal height measurements, routine ultrasound for fetal growth restriction in the third trimester did not reduce perinatal death in low risk pregnancies. Okay. Um, Risk factors for a small for gestational age, there's a lot of them. These include anything that would be a problem with the fetal placental unit, right? So like placental location, um, previas, filamentous cord insertions. Maternal smoking can be an issue with the placental unit. Any other substances or substance use as well. Chronic hypertension, gestational diabetes, pre-gestational diabetes, lupus even, antiphospholipid syndrome, cardiopulmonary or kidney disease that is severe, sickle cell disease. These things can all really increase risks for small for gestational age or fetal growth restriction as well. Even think about now malnutrition, right? Did mom have a low maternal pre-pregnancy weight or she has a poor pregnancy weight gain? Those things matter too. Also keep in mind any intrauterine space constraints that could restrict baby's growth. So if you already know they have fibroids that are taking up space, that's something you're going to want to think about. That would be an indication for an ultrasound for growth. Obviously, if they have multiples, we know that's always growth we need to be looking at too. Okay. When you start to see an estimated fetal weight and an abdominal circumference less than the third percentile, you know that these babies are at a higher risk for adverse perinatal morbidity and stillbirth. All right. They need to go to MFM. They really need to be looked at with some Dopplers and more specific testing. The risk for stillbirth is threefold higher for them, babies in the less than third percentile, than fetuses that are in the 3 to 5% range. And their risk for stillbirth is 4 to 7 times higher than a baby who's listed in the 5th to 10th percentile. Okay. So it is significant. If you start to get below that third percentile, it's quite risky. And these are patients you would really want to encourage to get some further testing and monitoring. All right, on to the next one. This is kind of the opposite. Now we're talking about accelerated fetal growth or large for gestational age or macrosomia. The definition of macrosomia that's widely used is about 4,500 grams. That's 9 pounds and 15 ounces. That's a big baby. Depending on the literature you look at, some will also use 4,000 grams. Large for gestational age is a fetus that weighs greater than the 90th percentile for gestational age. So just how they classify it's a little bit different. All this talk about estimated fetal weight, but you should know that we get it wrong a lot, especially with large babies. That is where we tend to overestimate. Prospective studies of fundal height measurements combined with Leopold's maneuvers, which we'll talk about, reported sensitivities of only about 10 to like 30% of positive predictive values for detecting macrosomia. So we're not great. We're not great at that. Ultrasound prediction of estimated fetal weight in a mom with diabetes tends to also overestimate fetal weight because the formula to get an estimated fetal weight uses abdominal circumference of the fetus. And fetuses in moms with diabetes, especially if they're uncontrolled, tend to have an increased abdominal circumference, but their overall weight may not necessarily be increased. I always joke that with all this genetic testing and the ability to like know the gender early, and you have these 3D ultrasounds where you can like tell what your baby looks like. I always joke that our biggest surprise anymore is baby's weight. It used to be, is it a boy? Is it a girl? Now it's like, what did it weigh? Like that's the part that we're just not as good about anymore. So that has definitely changed over time. All right, so on to the next one. Let's not forget about the other component that makes up that fundal height, right? Baby size matters, but also the amount of fluid around that baby matters. So oligohydramnios, polyhydramnios, these are abnormal amniotic fluid volumes that can adversely affect the pregnancy. And there's four probably of the main adverse effects that we do see. All right, on to the next one. You tend to see the amniotic fluid index listed and used most commonly on the bottom there of the slide. The AFI is calculated kind of by dividing the uterus into four quadrants using like the linea nigra, the right and the left, and the umbilicus is the upper and the lower divisions. Um, and then the maximal vertical amniotic fluid pocket diameter in each quadrant that doesn't contain any fetal extremities or the cord is measured, right? So getting the AFI is not easy. And then the sum of those measurements is the AFI, okay? Now, typically the radiologist will, or the technician will just record it for you and do the math and give it to you, but that's how it is computed. When you really get into looking at this, especially if you're delivering, a lot of times we want to know what that single deepest pocket is because that does matter. Okay. It's not always just the AFI, it's looking a little deeper. The values listed on here are those that are generally accepted, but you will see some variations across the board. All right. On to the next one. I'm going to be brief on these because it's unlikely you're doing these in your office. The idea with antenatal or antepartum testing, basically we're talking here mostly about NSTs or non-stress tests and biophysical profiles, which are ultrasounds. The idea is you have a patient you've identified who needs further testing, basically to rule out hypoxic injury or death, and you've sent them to labor and delivery or the appropriate place to have this testing completed, right? They're usually indicated around 32 weeks. We don't tend to do them much sooner than that. Sometimes we do. Remember, the NST is where they place two stretchy bands on mom's belly. One will monitor fetal heart rate pattern. The other will monitor the tone of the uterus. And then mom also usually has a little clicker or a little button or some way to denote when she feels the baby move. And then these NSTs are read and they're deemed reactive or non-reactive. Biophysical profile, it's really a very non-invasive ultrasound assessment for fetal well-being. Okay. All right, we'll move on to the next one. So this is the time when you start to narrow in on fetal position, 34 to 36 weeks. You would want to address an external cephalic version with a patient whose baby's not cephalic, so if the baby's breech, because the procedure is typically performed around 37 weeks, because you don't want to wait too long because the baby starts to get too big and the amount of fluid actually naturally decreases. So you need a little bit of fluid to still be able to turn the baby. So we can't wait too long. So by 34, 35-ish weeks, you should be starting to have this conversation in a baby who's still breech. If they want a version, we usually have to get them set up by 37 weeks. On to the next one here. A quick recap of how to determine fetal position. Y'all remember the Leopold maneuvers. There's basically 4 maneuvers to it. It is non-invasive, technically. I really do encourage at least obtaining the patient's verbal consent. Some places you may want to do a written consent. It is a relatively although non-invasive, you do have to really manipulate the uterus. And this can be uncomfortable for some patients, especially when you're trying to determine the presenting part, right? So like the fundal grip, you're looking what fetal part is in the fundus, so at the top of the belly. The umbilical grip, trying to determine where kind of the fetal spine and the limbs are. The pollic grip, another attempt to try to determine the presenting part. So if baby is head down, or you're trying to determine if it is, you're really kind of gripping down along that suprapubic, around the pubic bone. And it can be a little uncomfortable for patients, and some patients also feel uncomfortable with it. Okay. So sometimes getting consent or letting them know what you're going to do is a good idea, because some patients do actually fear that it's harmful to the baby. And it is not. We know this, but just make sure they know what you're doing. It is best to have an empty bladder. and this does have that clinician experience. It's hard. If you don't do them enough, your predictive value is going to be pretty low. So, elevated BMI can also, depending on their body habitus, elevated BMI can be difficult sometimes to feel via Leopold maneuver for position. Next one up is if you control click, and we don't have to do it on the next slide on the link at the top, just a quick like minute video on actually doing the Leopold maneuver. Okay. And again, we don't need to click on that in terms of time. You guys can do that on your own. On to the next slide here. Also take note around 36 weeks is the right time to be collecting or screening for that group B strep or group B beta hemolytic streptococcus, called group B strep, called GBS, all sorts of things. Primary risk factor for neonatal GBS is maternal colonization of that genitourinary and GI tract, right? So approximately 50% of women who are colonized with GBS will transmit the bacteria to their newborns. Okay. You do want to make sure that you are getting a vaginal rectal culture. Typically, they do recommend, obviously, you want to get from the posterior introitus down the perineum, and then they typically do recommend penetrating through the external rectal sphincter just a little bit for that rectal collection. A quick swipe right down their bottom is not typically adequate enough to get a good collection. So make sure that you're doing it right. Okay. If they have a positive group B strep, this does require antibiotics during labor. The recommended is for 4 hours, but 2 hours of antibiotics has been shown to reduce GBS vaginal colony counts, and also then neonatal complications. So if you do have patients, you're not going to say like, well, we didn't get your 4 hours in, you can't deliver yet. It just doesn't work that way. But if you can get 2 hours in, you can be pretty rest assured. But you do want to let pediatrics know of any group B positive moms. Babies are labeled as group B positive moms because they do tend to watch those babies a little bit more. Obviously, sometimes they check for fevers a little bit more often, all of those things. They also need to know if the antibiotics were given at all. Sometimes mom comes in pushing and you just can't get them in at all. Or if they were given for less than the 4 hours, right? That's all information that's very helpful for the pediatricians. All right, on to the next one here. In terms of fetal position around this time, you also want to be very aware of mom's perception. If a patient comes in and says, like, I had a really, really uncomfortable night, I feel like this baby completely flipped, it might be worth at least doing some Leopold, sometimes ultrasound, to see if baby did actually flip either the direction you wanted or the direction you didn't want. It's not common, but moms can really feel it at this point. It tends to be quite uncomfortable. So. All right, on to the next slide. All the normal things in these last 3 to 4 weekly appointments, except now we are making sure that all of our T's are crossed, all of our I's are dotted, and delivery could be at any time now, right? So we really want to plan for delivery. Again, does this always have to be in office? It might not have to be. If you have a pretty low risk patient who can't make it in, and some of this is just patient education, then maybe it could be done in a tele situation. All right, on to the next one. These are the items that I think are important to start discussing in the third trimester. There is no requirement for a formal birth plan. Please don't let patients stress themselves out about this. But you do want to at least discuss it, right? Have they thought about it? Do they have plans for pain management? What is their labor support looking like? Are they hiring a doula or some sort of pain labor support they'll likely need to get that all secured prior to the third trimester, certainly prior to delivery? Are they planning to have what's called a VBAC, which is a vaginal birth after a cesarean? Do they have an indication for a C-section? Do they know that they're an indication for a C-section and that that's the predicted route of delivery? How are they getting to the hospital in labor? That's a huge one. Some women just don't know. So that needs to be addressed as well. What are their thoughts on induction of labor? There are some indications for induction, in like they say, the 39th week. How do they feel about that? Induction is generally recommended for patients who've not delivered by a week over their due date. How do they feel about that? These are discussions that you can definitely start having with them at the later part of the third trimester. All right, on to the next one here. So speaking of delivery, it's also important to recognize possible delivery when we don't want it to be happening. This would be preterm. So anything prior really to 37 weeks. These are the common signs and symptoms. Now, a patient can have preterm uterine contractions that are not preterm labor. At first, you won't know because you have to kind of wait and see if these contractions are consistent and if they're causing the cervix to change. They're more concerning when you're starting to see that effacement and that dilation of the cervix. That is more indicative of preterm labor. Okay. On to the next slide. Switching gears now, we're going to go to preeclampsia. So this is the definition: new onset of blood pressure greater than 140 over 90 on at least 2 occasions, at least 4 hours apart after 20 weeks of gestation in a previously normotensive individual, and they need to have the proteinuria. And so this can be done with a 24-hour collection greater than or equal to 300, protein creatinine ratio of greater than or equal to 0.3, or the urine dipstick reading of 2 plus. Only use the dipstick if there are no other methods available. Okay. Um, in a patient with new onset hypertension without proteinuria, the diagnosis of preeclampsia can still be made if they have features of severe disease, and we'll touch on what those features are. So sometimes they won't initially have the protein, they'll only have the hypertension, and they may go straight to severe features, and we'll talk about those. Diagnosis is almost always made after 20 weeks. If you start seeing concerns for preeclampsia prior to 20 weeks, make sure you rule out a complete partial molar, or I should take that back, complete or partial molar pregnancy, or even like fetal hydrops. Okay. Go on to the next one here. Preeclampsia, 10 to 25% of women with gestational hypertension, we talked about that, I think, last webinar, will develop preeclampsia. Patient education about signs and symptoms of preeclampsia is huge. If they have gestational hypertension or even chronic hypertension, they need to know these signs and symptoms and that they need to be calling you. Okay. These are things that need to be investigated. Right. On to the next one, risk factors for preeclampsia. Obviously you can read through these. We just know these are the things that really tend to matter. And having a prior history of preeclampsia is definitely a big one. Okay. All right, so this slide then, a few slides ago, I mentioned that a patient can be diagnosed with preeclampsia with new onset hypertension, no protein in their urine if they have severe features. Here are those severe features, okay? Antihypertensive therapy is required to be initiated if a patient's reached that 160 over 110 mark for blood pressure to prevent maternal complications like eclampsia and stroke. Remember, antihypertensives, I misspoke there. Initiating antihypertensives will not prevent eclampsia or worsening preeclampsia. It will help prevent hypertensive concerns like stroke, all right? But for the prevention of something like eclampsia, you're going to need to add the magnesium sulfate, which is, the most known treatment other than delivery for preeclampsia, or I should say eclampsia, which is seizures. Down at the bottom, it talks about persistent cerebellar or visual disturbances. These are those like flashes of lights, dark areas or gaps in their vision, kind of blurry vision, worst headache I've ever had, despite taking Tylenol, kind of altered mental status. Like these are important things to recognize that puts them in the severe features category, okay? Treatment for preeclampsia with severe features will be delivery, IV magnesium sulfate, and remember, they're going to continue the IV mag for about 24 hours postpartum. Again, trying to decrease her risk for maternal stroke, maternal hypertensive crisis of any sort, and seizure. All right, on to the next one here. Once the diagnosis has been made for preeclampsia, the balance becomes keeping blood pressures out of severe ranges, preventing maternal seizures while trying to prolong the pregnancy until term to promote that fetal lung development and maturity, right? It's amazing if you've practiced for a while. anybody who was preeclamptic was like in the hospital, they were sick, we were watching them. And then as I started to move through my career, and things have changed now, there's a lot of preeclamptic patients, mild preeclamptic patients who are just walking down the street. And being someone who before we knew they were like in the hospital on bed rest, which we don't do anymore, scares me a little bit. But we know with experience now that they don't all necessarily, if they're not having severe features, we can continue to watch them. Um, Listed here for you is when delivery would be indicated based on severe features versus no severe features. Okay. Um, Moving on to the next slide here. This is the severe features. They really, really do kind of break it down. If they're greater than or equal to 34 weeks when they get diagnosis of severe features with preeclampsia, delivery is indicated at that point. Okay. If they're less than 34 weeks, you can choose expectant management. And if those indicators are hit, so mother and fetus are stable, mother and fetus can be monitored inpatient with appropriate level of newborn care, and they have access to MFM. If they are less than 34 weeks of gestation, mom and baby are not stable, pregnancy has not yet reached an age of viability, then typically delivery is indicated, especially if this is happening really early on. All right. Move on to the next one here. Generally, a patient with predicted preeclampsia or suspected preeclampsia will go inpatient first to monitor for the severity and kind of the rate of their progression. If appropriate, then they will go outpatient. And those are the ones I'm talking about that kind of scare some of us older people. There are some lab tests that are FDA approved that can be used to try to like predict their risk of progressing. That can kind of help make the decision if they can go outpatient. But I will say that ACOG, American College of OBGYN, kind of limits the utilization of these tests to only inpatient. And in a very strict time frame. So really only like 23 weeks to like 34 and some change. So the reality is these tests are not routinely like being incorporated into clinical practice. They're not being used all that much yet. If the patient is outpatient, or if the patient is outpatient, these are the things we typically encourage. The biggest one that I think is going to become an issue in our rural areas is that they are able to reside close to a hospital and have someone with them at all times. That's going to be really difficult. We may be safe to be watching them outpatient in all other parameters, but if they don't have anybody who can be with them or that could bring them to a hospital if they developed severe features, then maybe it's not the safest option. And that's something you're going to have to kind of monitor back and forth with your patients. The modified physical activity really just involves no heavy lifting, several hours of like daytime rest with feet elevated, relaxation techniques, so they're not overly proven, but they're not this is not bed rest anymore. Okay. All right, I'm going to skip ahead here just because of the sake of time, we're going to run out. This is the differential for preeclampsia. Moving on to the next one, between 20 to 50% of patients with chronic hypertension will also develop superimposed preeclampsia. So you have to be on a lookout for this in your chronic hypertensives. Look for these 3 bullets that can happen. They have elevated pressures, they have new onset proteinuria, and this like sudden large increase in protein excretion, even on the dip, then you should start to be a little concerned about superimposed preeclampsia on these patients. Moving on to the next one. Again, it can be very difficult to distinguish between chronic hypertension exacerbation and superimposed preeclampsia. There is a debate on the utility of using like serum uric acid levels in diagnosing superimposed preeclampsia. In chronic hypertension, the uric acid level is usually not elevated, but in superimposed preeclampsia, it typically is. So sometimes they will use that, but you definitely want to look at their liver function as well. And if they do have superimposed preeclampsia with severe features, abnormal lab values, or they're symptomatic with that worst headache of their life, visual changes, then we do typically deliver by about 34 weeks. All right, on to the next one here. Eclampsia, plain and simple, new onset generalized seizure in a patient with preeclampsia that cannot be attributed to other causes such as medications or illicit drugs. And the goal really is to prevent anyone from getting this far. All right, and last one here is HELP syndrome. Some schools of thought will place HELP as a subtype of preeclampsia with severe features. Others place it as like their own separate disorder. Those who support the subtype of preeclampsia will say that, like 80 some percent of patients with HELP will have hypertension and 80 to 100% will have proteinuria. Although it's rare, it is possible to have HELP with neither high blood pressure or proteinuria. Okay. So hypertension does not always have to be present for this diagnosis. In most cases of severe preeclampsia with severe features, they will have significantly elevated blood pressures, thrombocytopenia, liver dysfunction, but those levels are not typically as abnormal as they are with HELP. Okay. HELP syndrome, I should say. Gonna move on to the next one here. So this is, I'm going to probably breeze through these, even though ICP is interesting. Intrahepatic cholestasis of pregnancy. I do encourage you kind of read up on this. This is that, it could be in the second and third trimester. This is that patient who comes in complaining of itching of it can be generalized, but typically it's the palms, the soles of their feet, and it is worse at night. And, again, back when I first started practicing, we didn't really make a big deal about it. We told them to use some hydrocortisone, Benadryl cream, which by the way, don't really work. And move on. Now we know that there's an increased risk with fetal risk for these patients. Stillbirth, we definitely see an increased risk for stillbirth with these patients. Maternal risks are pretty minimal. Really, it's the discomfort of the itching. There does seem to be a little genetic component. A lot of people who have had it before will have it in ongoing pregnancies. I remember we had a surrogate one time, and I don't think anymore she would have been approved to be a surrogate given what we know about ICP. She had all the symptoms with her first two pregnancies, which she kept. Her third pregnancy was a surrogacy. She developed ICP pretty significantly. We were seeing her for her fourth pregnancy, which also was a ICP pregnancy. We ended up delivering her early and doing a lot of antenatal testing because of the risk of stillbirth. And so I think thankfully she was done because she'd had too many babies at that point in terms of surrogacy. But I don't think she would have been approved in this day and age, what we know now about the potential for stillbirth. Okay. I do say minimal maternal risks, but there was a study out of Sweden that was looking at possible increased risk for preeclampsia in patients with ICP, because why not, right? Like apparently everyone needs to have preeclampsia. So there is potentially a link there. So, all right. Gonna move on here to the next one. Labs. Bile acids, serum bile acids, this is what we want. Do know what your local labs have. You don't really need a fractionated bile acid. Really, the total serum bile acid is the value that we need. Elevated LFTs can sometimes be seen with ICP, but are not necessary for the diagnosis. Typically greater than 10 micromoles per liter is the cutoff for diagnosis. Greater than 40 micromoles is where you start to see significant risk of adverse perinatal things. There's been efforts to try to label ICP as like mild, moderate, and severe based on their serum bile acid levels. Severe would be over 100. So that hasn't really been set in stone yet, but we definitely see that labeling coming. Okay. Sometimes repeating labs are used to help kind of guide the timing of delivery, especially in severe cases, but otherwise serial testing is not indicated. If you get serum bile acids greater than 10 micromoles, they have it. You don't need to keep testing them. A lot of times though, the itching really precedes the rise in serum bile acids, usually by a few weeks. So if they're really itchy and their classic symptoms, hand, palms, soles, worse at night, give it a few weeks and retest it. It may then have elevated and they may actually get the diagnosis later. Some clinicians will make the diagnosis based on their clinical symptoms and they'll start treatment, which is with the URSO. And remember, if you do that, it's going to affect their lab values. There's really no point in drawing bile acids after you've started the treatment. Okay. If You do want to repeat labs postpartum if the symptoms are lasting greater than about 4 weeks after delivery. They should start to subside after the delivery. If they don't, you want to look into more significant liver issues. Okay. Starting the urso does help the maternal symptoms, usually within about 1 to 2 weeks, but you're not going to see a change in their bile acids for 3 to 4 weeks. But again, there's really no reason that you need to be checking them. And again, we talked, there's limited improvement with like antihistamines, topical anti-itching. None of it seems to work for them. Patients get kind of frustrated with you when you're like, just put some Benadryl cream on it. Doesn't seem to work. All right. On to the next one here. Because of the risk of stillbirth, antepartum testing is typically uh, indicated. The problem is the mechanism of the stillbirth is thought to be kind of like a sudden event rather than this chronic cumulative process. So the idea of doing like non-stress tests once or twice a week, every week after the diagnosis, it's being done, but we're just not quite sure yet if that's the right thing to do because we're not sure we would necessarily catch it. On to the next one. Timing of delivery involves that balance between stillbirth and fetal lung maturity. I have them all kind of laid out here for you. In the sake of time, I'm not going to read them. Make sure you do administer antenatal corticosteroids for lung maturity if you're going to be delivering before 37 weeks and it hasn't been given yet. Okay. All right, switching gears a little bit, but staying consistent with the other lectures, I wanted to mention vaccines. Obviously, the flu is fine, the Tdap. RSV is a seasonal one. So typically around 32 to 37 weeks during RSV season, which in the US is usually like September to January. And they're not planning to give birth within the next 2 weeks, then they recommend giving the RSV. You do want to not use the Arexvy if you can. It is not FDA approved in pregnancy yet. It does create kind of a stronger response than the other, and so it's just not the one we're using right now. It's also okay for the patient to not get the RSV vaccine during pregnancy and instead plan for like a postnatal administration for the infant. That is fine as well. All right, third trimester, good time to start discussing some events that happen directly after birth for the patient needs to be prepared for, right? What are we going to do for birth control? Who's going to follow your chronic medical conditions? What are we doing for breastfeeding? Choosing a pediatrician. Does the baby need circumcised? Are you going to do circumcision? Who's going to do it? And then what is their postpartum support going to look like? This is huge in the third trimester. And again, patient education may not have to be in person. All right, last part here. I want to end this presentation with this important part of the third trimester as the patient is preparing for delivery, and that is transitioning to the delivering provider. So in my view, the first step before caring for pregnant patients in general is establishing this kind of strong face-to-face relationship with the delivering providers in your community, right? Building the trust, having that open communication and this collaborative partnership is essential to providing this like very safe and effective care. There must also be transparency about the role that we are serving within the healthcare system. Prenatal care in the primary care setting is not intended to replace obstetric care for patients who already have access to an OB provider. It's designed to support those patients who, for a variety of reasons, some of which we know, may not otherwise receive prenatal care at all or very limited. As primary care providers, right, we are embedded within these communities. We understand these challenges our patients are in, and we are at the position to provide this very passionate, comprehensive care that supports them as whole people. And that includes their time during pregnancy. Okay. In the perfect world, the prenatal care that you are providing is a replication of the care that the local OBs would provide. When it's time to transition care to delivering providers in the third trimester, the transition should be seamless, right? It should just be like a warm handoff if that communication has been there. The testing, the management of results should be complete up until the point of transition, whenever that might be. In this role, it's important for us to ensure the patient knows from the beginning of care that we do not intend to be their delivering provider and that the transition to delivering will need to happen. Despite our best efforts and all of our patient education, there will be individuals who continue their prenatal care with us all the way until delivery. Most often, this is due to significant barriers they face accessing care, transportation, all of the things. Many of these patients are willing and able to make the longer trip for delivery itself, but not for routine prenatal visits. And that means that we have them up until delivery and we're going to have them postpartum, and we need to know that. I view this not as a limitation, but as a success, right? By providing accessible prenatal care within these patients' communities, we're ensuring that they receive support, monitoring, and intervention during what is one of the most like critical periods of their lives, including postpartum. The impact of this can't be overstated. Studies consistently show that women who receive no prenatal care are 3 to 4 times more likely to die from pregnancy-related complications compared to those receive adequate care. Even more importantly, more than 80% of pregnancy-related deaths are considered preventable. This is why our role matters, right? If we are seeing these patients, building the trust with them, providing consistent care, then we are part of that 80% of prevention. And we're improving access, we're reducing risks, and we're helping create those better healthy outcomes for moms, babies, and the whole communities that we live in. And that is just like the whole point of these webinars for me. All right. Um, Moving on to the next one. I think that is the end of next and last postpartum care. That'll be on July 30th. And there is my contact information next. And then the last one should just be my references. And then looks like we do have just a couple minutes for questions if anybody has any. I thought I saw one pop up in the chat, but I didn't read it.
We do have one in the chat. Do we know what is the conversion from those who enter pregnancy with a hypertension diagnosis into preeclampsia?
So chronic hypertension to preeclamptic, off the top of my head, I do not. Yeah, the gestational hypertensive to preeclamptic is higher. Chronic hypertension to preeclampsia is not quite as high, but the exact number I would not be able to give you. I could look it up though and send it to you. And then, you could pass it on if that works, Christy.
We'd be happy to put it in the follow-up email. Yeah.
Yeah, let's do that. Let's do
Okay.
that.
And then if anybody else has other questions, feel free to type them in the chat or unmute to ask.
Hey, this is Lucia with United Healthcare. Christina, do you mind? I know you went over this, but it's still a little bit not all the way clear in my brain. So I understand that for eclampsia, the treatment will be the magnesium sulfate. Now, when the patient has chronic hypertension, most of them will be in a hypertensive medication. When they develop hypertension in pregnancy, can you clarify, do you treat that hypertension or not when it's developing pregnancy?
That's a good question. That was one little part that I skipped over in the matter of time. Yes, you can treat it, but you just have to be so aware of what you may be masking, right? You may be masking some of those severe features that included the visual changes, the headaches, things of that sort, but that is worth it to decrease your risk in terms of maternal stroke. So you have to be very aware of what you're masking. But yes, most providers are going to start when they've reached the 160 over 110. 140 over 90, most will not start the antihypertensives. And again, the main reason for that is the goal to try to not mask the progression. I will say those patients are typically being followed very closely. There's a lot of times in this situation, home monitoring that's being done, calling the blood pressures in on a regular basis, being instructed to call the clinic with blood pressures of 160 over 110 and or preeclamptic symptoms. Patients are very aggressively monitored, especially when they're being done outpatient.
Thank you. And follow
Yeah.
up to that. Once the member So if the provider decides not to treat the hypertension because we have a blood pressure with no symptom, I mean, a normal 140, whatever,
Yeah.
150, and the patient does develop the preeclampsia, what I understood is there is not an actual treatment once you develop the preeclampsia. You just have to closely monitor. Um, and then the only treatment will be to deliver the baby once if he gets into symptomatic preeclampsia type of thing. Correct?
Exactly, exactly. Preeclampsia does not have a treatment other than delivery. That's it. And so the hardest part about preeclampsia really has been, and as a provider, what makes it kind of scary for us is there are right now no significant predictive ways to know how a patient's going to progress. I've just seen it, the patient, you're looking at them, they just look sick, and you think that this isn't going to go well. They're going to progress quickly. And they don't. They never change. They stay in the same blood pressure ranges. They never develop symptoms. And you have another one who has elevated pressures and she doesn't even know it. They're severe or they're just below severe. And overnight she changes. So that is where it gets difficult, especially with our rural patients. And patient education is going to be our biggest thing. And I still think we err on the side of caution if we can get them hospitalized to watch initially um, what their progression is looking like. I think that's important. And then if we can move them to outpatient for a little bit, get them back home for a while, once we feel like, okay, this doesn't seem to be someone who's moving quickly, then yeah, all we do is watch and wait until we can get them to an age of obviously viability, and then 37 weeks if we can. Yes, sometimes we do deliver before that. I hope that answered your question, Lucia.
It sure did. Thank you so much.
Yeah.
Well, I'm not seeing any other questions in the chat. If you do have any, feel free to send them to us afterwards, and we'll be sure to get them to Christina. We want to say thank you to Christina for sharing about third trimester care, and thanks everyone for joining us today. We will send a follow-up email that includes the slides, the recording, information on claiming your CE credits, and the question that was asked. So just watch for that in the next couple of days, and we hope you can join us for the final session on Thursday, July 30th at noon, our time, to discuss postpartum care. So thanks, everybody, and have a great rest of your day.